Good evening, all the aspirants present here. Today, we are going to have a discussion on neurological disorder. It is a class 2, and the speaker that we have here is Dr. Varun Pushkarna. He is a senior consultant in internal medicine at Fortis Escortis Hospital, Amritsar. So, you may take over. Thank you.
Thank you, Sana. I hope the slide is clear and visible.
Yes, sir.
Okay, great. So, welcome, students. So, we'll be covering the second part of the neurological uh, diseases for EDIC part 1. And we'll begin with the MCQ so that we cover all the important topics, and then we go through the brief, discussion of all the topics that we will share. So the first question, and I'll be letting you know the topic of question already so that your mind runs like that. But then eventually in the examination, you will not be given the topic along with. So focus on everything as if you don't know the topic. A 42-year-old man presents to the emergency department with progressive weakness in his legs for the past 3 weeks. He has a history of diarrheal illness 1 week back. Neurological examination shows areflexia and bilateral lower limb weakness. He's now developing shallow breathing. ABG shows a normal pH with CO2 of 29 and oxygen of 85 on room air. Which of the following is most appropriate step in the management of this patient? Start high dose methylprednisone, obtain a contrast MRI of the spine, begin IVIG, intubate the patient and initiate the mechanical ventilation, or start the plasmapheresis and corticosteroids. Anybody? Hello, yes? So the correct answer here will be anyone? So this patient basically looks like to have a progressive neuromuscular deficiency, which is ascending in pattern, which is most likely fitting in the bracket of Guillain-Barré syndrome. Now the thing is that this patient has now developed a shallow breathing. Shallow breathing means signs of respiratory muscular weakness. So this is the clue to the answer. So the CO2 is started to get washed out. PO2 is okay, although a bit low, but then still okay. So this patient basically is developing a respiratory muscle involvement. And we all know when the respiratory muscle involvement begins in a patient of GBS, the patient needs intubation and ventilation on elective basis. Now, this is where the intensivist's role comes in, to identify those patients who will and are in the immediate need of intubation and ventilation. So this patient has all the signs of impending respiratory failure. Now, am I audible to all of you? Hello? Hello?
Yes, sir, you're
Am I
audible.
audible? Yeah. So basically, as an intensivist and a candidate who is appearing for EDIC examination, it is very important for you all to understand and know when the patient will start needing intubation. If the patient collapses, even the staff nurse can tell you that the patient has collapsed. Now, please intubate this patient. But as an intensivist, it is your responsibility to identify the patients when they are in an impending respiratory failure. That means if you intervene now, there are high chances of the patient survival. So this patient will need intubation and mechanical ventilation. So correct answer is intubate the patient and initiate mechanical ventilation. This patient is showing clear-cut signs of respiratory muscle involvement. Tachypnea is there, PaCO2 is low, shallow breathing is there, and we know the diagnosis of GBS is there. And unless intervened by a IVIG and probably plasmapheresis, the patient is not going to get better. So you should make arrangements for the safe administration of IVIG or carrying out a plasmapheresis, but before that, the patient should remain alive. So if that doesn't happen, then there is no fun of knowing what to do and when. So intubate the patient when the patient has started to show earliest signs of respiratory depression, which is tachypnea, not maintaining CO2 levels, CO2 falling down, and the obvious visible using of the respiratory accessory muscles. So once the patient is intubated, you can always take up this patient for a plasmapheresis or IVIG afterwards. Now, what is your stand on corticosteroids in GBS? Anyone?
Corticosteroids are contraindicated in GBS.
Correct. So these steroids, they have no role to play in Guillain-Barré syndrome. If at all, the data is only for IVIG and plasmapheresis or combination of both. So the survival benefit is there with only these two modalities. Some people have also used rituximab, but then this is such an acute onset disease that only IVIG or removing the antibiotics, the antibodies that are affecting and causing Guillain-Barré syndrome, they need to be effectively removed from the system. So that is the only plausible treatment. MRI spine is not required because the diagnosis, how will you diagnose GBS? Anyone?
Nerve conduction study.
So number one, the diagnosis of GBS is basically based on very high clinical suspicion. So why? Because the patient's clinical presentation will be such that the patient will have a respiratory depression after a long standing ascending kind of a paralysis. So the patient will give you a history. Now the prognosis worsens with the length of time required for the paralysis to reach the respiratory level. So if somebody has had a tingling sensation on their feet last night and today they are not able to breathe in the morning, then this patient is most likely an axonal variant and a very aggressive type of Guillain-Barré. But otherwise, many times, many patients, they will tell you that 3-4 days ago, I started having this numbness feeling in my feet. Is there any other condition that you can pinpoint which can mimic Guillain-Barré syndrome in Indian settings? Because we are talking of the clinical suspicion. Anything else than Guillain-Barré which can mimic the same progressive paralysis? Sometimes it is the whole body paralysis, but usually I have seen few patients who also present with the similar feature. It is basically snake bite envenomation. So many times when happen is somebody got bitten by a snake and then a neurotoxic snake, and the dose of the venom was mild or moderate or somewhere in between. So not a lethal dose, not something which will cause immediate respiratory paralysis. So these patients will come to you after 3-4 days, and then you will many times need to assess the patient on the basis of snake bite envenomation also. Nevertheless, the data tells us that if you give IVIG even in snake bite, it's going to make the things better only. So the thing is, we as intensivists, we need to know and understand if the patient requires intubation and ventilation now, or we can delay it. So whenever we see such a patient, we should ask ourselves, will this patient survive with this feature that is there, that is sudden onset tachypnea, using of nasal and other accessory muscles? If you feel that this patient will not survive, then immediately intubate and secure the patient, and later on you give whatever you want to give. All right. Next question is on a similar neuromuscular emergency, that is myasthenic crisis. So in whole of the neurology, myasthenia gravis is taught, and whole of the medicine, myasthenia gravis is taught. But as an intensivist appearing for EDIC exam, the knowledge of the crisis situation that occurs in myasthenia is important for us. Why? Because myasthenia gravis can be managed on OPD also, OPD basis also. But it is only when the patient reaches a threshold where the patient needs to be addressed by an intensivist, that is called myasthenic crisis. So, a 63-year-old woman with known myasthenia gravis presents to the emergency room with increasing difficulty in swallowing, ptosis, shortness of breath over the last 24 hours. Whatever may be the reason, some medicine may be the reason, some viral infection may be the reason, some stressors may be the reason. We are concerned about the reason only after the patient has been secured. So we need to know if the patient needs securing right now. So the patient has a history of myasthenia gravis, has been on treatment. Now the patient is having increasing difficulty in swallowing, doses, and shortness of breath. She has had a recent respiratory tract infection and she is alert. The blood pressure is 130/75. Respiratory rate is 28. Saturation is 90% on room air. Which of the following is the most appropriate immediate intervention? Administer oral pyridostigmine, give IV corticosteroids, intubate and admit to the ICU, start broad spectrum antibiotics, या perform tensilon test. So the answer here also will be elective intubation of this patient. Why? Because this is myasthenia gravis with respiratory compromise. What are the features which are telling us? Number one is respiratory rate of 28 and number two is saturation of 90. Although the patient is alert, if you take a stand that this patient needs intubation, then you obviously will sedate this patient and then ventilate. But don't be ashamed of telling that this patient is going to crash in next 30 minutes. If we don't intervene now, we will have a dead patient or a patient who has crashed and we will be doing CPR. We can avoid that now. So what are the pointers? Number one is the respiratory rate of 28. What is the normal respiratory rate of human beings?
Around 18.
Yes, again?
Around 18.
So 12 to 15 is the normal respiratory rate with an average mean of 14. So if somebody is having anything more than 16, it is called an onset of respiratory distress. Anything above 20 is moderate respiratory distress. Anything above 30 is the defining criteria for quick SOFA. You remember quick SOFA? Quick SOFA for septic shock. So there the three main features are CNS obtundation, blood pressure of less than 80, respiratory rate of more than 30. So that is severe respiratory distress. So anything from 16 to 20 is mild respiratory distress, 20 to 30 is moderate, and more than 30 is severe respiratory distress. So this means before the patient lands up into severe respiratory distress, you have to intervene and intubate the patient just based on these two pointers. Forget it that the blood pressure is normal. Forget that the patient is alert. The patient may not remain alert in some time. And many people may have a contradictory response that why not try oral pyridostigmine? Why not give IV corticosteroids and wait? IV corticosteroids? Anybody? Any opinion about IV corticosteroids? So IV corticosteroids usually worsen the patient. It is only after the crisis situation has gone that you can start steroids. If you start immediately IV corticosteroid, then the patient will only worsen. And the patient who has not required intubation as of now will require it after the IV steroid has been given. So it is wrong to give IV steroids. Administering oral pyridostigmine is again contraindicated when the patient is impaired swallowing. See, she has a chief complaint that the patient has difficulty in swallowing. So dysphagia is set in. And if we give oral pyridostigmine to this patient, the patient might aspirate pyridostigmine into their respiratory airways. So one is wrong, second is wrong. Intubation is the right answer. Starting broad spectrum antibiotics is just a supportive act. It is not going to be immediate life-saving step in this patient. And what about performing tensilon test? Anyone? So tensilon test basically is a diagnostic for myasthenia. This is already a diagnosed case. You will not need to make a diagnosis. So it is a diagnosed case of myasthenia. So this answer is also out. This is also out. So the only answer is intubating the patient and admitting to the ICU. Always remember, if you are going for an EDIC exam, be prepared to be challenged for a situation where you will be required to be assessed as an intensivist, because this is an intensive care exam. So you must be having a very good insight of when to do what. We will be going into the details of all the questions, but before I'll just share the questions with you. All right. The next question is about botulism. A 28-year-old man presents with diplopia, dry mouth, and progressive descending weakness. Progressive descending weakness. So in Guillain-Barré, it is usually ascending weakness. In botulism, it is descending weakness. He reports eating home canned vegetables 48 hours ago. He is alert. His pupils are fixed and dilated, and deep tendon reflexes are reduced. No sensory loss is noted. Which of the following is the most characteristic of this condition? Number one, normal pupils with upgoing planters. Number two, preserved reflexes with patchy sensory loss. Number three, ascending flaccid paralysis and preserved cranial nerves. Number four, symmetrical descending flaccid paralysis with autonomic dysfunction, or acute spastic quadriparesis with preserved consciousness. What is the answer? Anyone?
Descending reflex.
So it is a symmetrical descending flaccid paralysis with autonomic dysfunction. Okay. So botulinum is usually defined with this criteria, that the patient has descending paralysis starting with cranial nerves. So remember ophthalmoplegia, facial nerve loss, trigeminal loss. So these are all present. Gag reflex will be gone. These patients usually have cranial nerve involvement as the first step. In Guillain-Barré syndrome, the cranial nerve involvement, for example, ophthalmoplegia, it usually comes later in the course. So in botulism, it is the reverse pattern. Cranial nerves first and then the descending pattern of the paralysis. The autonomic signs like dry mouth, fixed pupils, hypotension, they are pretty common. Reflexes are either absent or they are very decreased. Sensation, that is cutaneous, the dorsal column is usually preserved. Differentiating factor from Guillain-Barré is number one, the trend of the paralysis, that is ascending paralysis in Guillain-Barré and descending paralysis in botulism, and central causes. For example, spasticity, altered consciousness. These are basically the central brain causes which cause similar presentation, and we need to make a differential diagnosis from botulism. So that was about botulism. Remember, we will discuss each question in detail, but first we will have discussion on the questions right here. Okay, critical illness myopathy or polyneuropathy or CIP or CIM. A 68-year-old patient in ICU was there for 3 weeks with a diagnosis of sepsis. The patient was on ventilation and multiple organ failure was there. Eventually, the patient recovered, is still on ventilator, and we do not have a proper weaning off from the ventilator. That means it's a failure to wean off. Neurological examination shows diffuse weakness, especially proximal weakness, with decreased deep tendon reflexes and intact sensation. The nerve conduction study shows low amplitude CMAPs with preserved snaps. What is the most likely diagnosis? Can it be Guillain-Barré or myasthenia gravis or botulism? No. Can it be conversion disorder? It is very difficult to say conversion disorder in such a setting. Conversion disorder usually happens in a patient of outpatient setting, not an inpatient or a critically ill patient. So this is critical illness polyneuropathy. Now this typically occurs in ICU patients with history of septicemia and multi-organ involvement, weaning of failure, diffuse weakness, and the present preservation of sensation are characteristic. Nerve conduction studies, they help in differentiate this condition from others. Why? Because in critical illness neuropathy, there is low CMAPs, there are preserved snaps, which are pointing to axonal neuropathy presenting as proximal myopathy.